So a little change of pace here. These are my disclosures, and the one disclosure I do want to point some attention to is that several of these images were provided by my friend Dr. Carlos Timoran, who is a strong advocate of IVUS during complex aortic repair. So let me start with the case. This is a 29-year-old woman with a past medical history of hypertension who presented to the hospital after experiencing a popping sensation and abdominal pain radiating to her back. She had a strong family history of aortic pathology, including a mother with a ruptured aneurysm, maternal grandmother and uncle with aortic dissection, and her mother had been tested for several connective tissue disorders and were negative. Physical exam, she was writhing with abdominal and back pain. She had a pulseless right leg with decreased motor strength and was numb below the knee. Her CTA clearly showed an acute type B aortic dissection beginning at the left subclavian, near occlusion of a very collapsed true lumen. The celiac was occluded, the SMA was occluded, the right renal was occluded with clear malperfusion of the right kidney, and the left renal was perfused but came off the false lumen, and the dissection extended into the right common iliac with focal occlusion just distal to a narrow true lumen. So we start this type of case with bilateral percutaneous access and use IVUS to confirm location within the true lumen from the femoral all the way up to the aortic valve. And I think this is where IVUS is really key in making sure that you don't traverse the septum at any point and go true to false and then back to true. This patient had a TEVAR graft to cover from the entry tear to the celiac artery. After that, the celiac and right renal could be seen to be open status post the TEVAR. But the SMA, and you can see that here, was open at its origin, but then acutely occluded. We placed a stent, then we placed kissing iliac stents for right lower extremity malperfusion. The patient was discharged on post-op day 3, and this is her 4-year post-op imaging from last week, showing that the intact repair. So this is really, I think, the sweet spot, that is dissection, but there are several other routine uses where IVUS can really play a role in complex aortic repair. So it can be a very useful tool for seal zone evaluation. This study out of China showed 47 complicated type B dissection patients where the average diameter values of IVUS measurements in the landing zone were greater than those estimated by CTA by 3 to 5 millimeters, which would change the endograft size, and the technical success rate using IVUS was 100%. Also, it can be used at the start of a case to confirm and adjust fusion overlay markers. Here you can see we're moving our fusion mask based on where we see the origin of the artery based on live IVUS. It's also helpful for IVUS-assisted fusion guidance for cannulation. So you can see here what was a tough downward branch for a renal artery where we can watch in real time with IVUS as that wire approaches the origin and then adjust that wire, and you see that white dot at the arrow enter the target artery right there. I think for branch cannulation confirmation, it can be very useful, specifically in aortic arch work. It can be difficult to know you're in the branch as opposed to right anterior or posterior to it. Traditionally, what we've always done in our practice, which you can see in this video, is we put in a hooked reverse curve catheter, and then we hook it on those 2 dots, which represents the inner branch. You can see it hooking right there. But that does involve some manipulation in the aortic endograft and in the arch. I think a more elegant way, shown here by a slide from Dr. Timoran, you can see this IVUS going in and out of that inner branch, clearly showing that you're within the inner branch and not to the left or right of it. I think finally, thermal septotomy is something we've started to do more of to get a narrow true lumen to merge with a false lumen. So here you can see we're going across using a electrified wire. And what we do is we put IVUS in the true lumen. We work with a steerable sheath from the false lumen, and you can see that wire going right across. You can use IVUS as a perfect target, and it really shows you in real time as it traverses. So in my opinion, for dissection, IVUS is absolutely necessary. It increases efficiency and it increases safety. I think potential routine uses in complex aortic repair include seal zone evaluation, optimization of a fusion mask, an adjunct to fusion for guidance of a wire, branch cannulation confirmation specifically useful in these arch repairs, and thermal septotomy. Thanks so much for the opportunity to be a part of the program. I appreciate your attention.